We've got a lot of people attending. So I'll just quickly introduce you, and then you can say a little bit about your road to realism, John. And yeah, we're really looking forward to hearing from you. So John, I've known for many years. John was originally based, or at least in terms of the time that I knew him, at the University of East Anglia, where John did a most excellent PhD, which used realist approaches. John's now at Queen Mary, where he's senior clinical lecturer in health equity, one of those rare people that managed to escape from Norfolk, which is something I never really managed to achieve. And it's great to see, the work that you're up to now, John. So I'm going to pass over to you. The mic's yours. We like to leave a little bit of time for discussion on these webinars. So if you can do that, that's fantastic. If people want to put questions in the chat, then we can return to them at the end of the presentation. So we can take a sort of mix of verbal questions and chat-based ones. Right, over to you, John.
Great, thanks, Andy. Delighted to be here with you. Lovely to see some familiar names on the call. So for those of you who don't know me, I'm an academic public health doctor, so I spend most of my time doing research at Queen Mary University, where I lead a program of research around health inequalities. I'm also a consultant in public health with NHS England, where I do that 1 day a week. I started my PhD with Andy about 9 years ago, which is a delight. And I guess that was my first experience or use of realist methods. I guess in terms of a bit of background about how I got into realist methods. So after doing junior doctor, did a few years of being a junior doctor, I then worked for NICE for a couple of years. So we're doing evidence reviewing for NICE. And that was new drugs which came, which were proposed for the NHS. We looked at the clinical cost effectiveness. They use NICE, as you probably are aware, use fairly robust, rigorous methods. They follow a very strict process, just similar to that used by Cochrane. Excellent for drug trials, and also good for complex interventions. So, when we start thinking about actually what works to address inequalities in primary care, which is what I did my PhD on, or if we start looking at complex healthcare interventions, then I was finding these methods didn't really work. I think I had a bit of an epiphany in Norfolk County Council, where we had a journal club looking at obesity and complex interventions to address obesity. And so we looked at this. We got this systematic review from, I don't know, it was from the Lancet and New England Journal, one of these big impact journals. We got a really academically excellent systematic review, and they'd done this meta-analysis and come up with an odds ratio about whether a certain type of, it was tier 3 weight management, whether tier 3 weight management services were effective in reducing obesity. And so they came up with this odds ratio, and whether it was effective or not. And I remember just thinking to myself, this is nonsense. Actually, how can one, how can we boil down a complex intervention like tier 3 weight management services down into one figure about whether it works or not? Because we were sitting there in Norfolk County Council trying to work out what we should be doing around tier 3 weight management services. And so I think that kind of got me on the train of thinking about actually context is really important. And actually, just because something works in the US, London, Leeds, Birmingham, it might not work in Norfolk. So that got me on to realism. And so today, I've got a presentation of about 20 odd slides. I'll kind of go through realist as a methodology, and then hopefully we'll have plenty of time for discussion and questions at the end. So let me just share my screen. Nope, you can see that. I'm sharing my screen on this. Okay, hopefully you can see that. So I'll go a bit through realist approaches. I'll cover both realist reviews and realist evaluations. We'll talk a bit more about that in a minute. Okay, so the plan for the next 20 minutes, 25 minutes is I'll run through what realist research is, some underpinning assumptions, and then I'll give an example of some realist work which I'm doing just now, and I'll have a summary and hopefully a bit of discussion then. So the aim of today is really to try and understand what realist research is, what it's not, and actually how it might add value to either the current research you're doing or whether you're thinking about an evaluation in a local authority or an NHS setting, and how do we start thinking about complexity and context in that way. So let's kick off. So in terms of realist research, there's two main branches of realist research. So there's the realist review or synthesis. So that's like a literature review, and that uses other previous published research to come up with that to do a literature review. And then there's realist evaluation, and that collects primary studies. Those are the two main distinctions. Within realist evaluation, you can do realist interviews. There's realist case studies. There's different elements of realist evaluation. Within realist evaluation, it's important to note that realist research is methods neutral in the sense that it incorporates both quantitative and qualitative data. As you come on to see when we start talking about mechanisms and context, it draws heavily from qualitative data, but it's not necessarily a qualitative method. It's a methods neutral. The aim of realist reviews and realist evaluation is to have more of an exploratory approach rather than judgmental. So instead of that meta-analysis, which I was describing around tier 3 weight management, which came to judgment about whether something works or not, and an odds ratio, realist reviews and evaluations tries to be more explanatory. So it tries to understand what are the benefits and drawbacks and why do they occur and who do they work better for or not. So it's much more, I guess, open-ended, tries not to be reductionist. It's based on a very clear philosophical paradigm called realist philosophy of science. For those of you who are familiar with kind of philosophical paradigms, it sits between kind of positivism and interpretivism. And the realist philosophy of science kind of states that there is a observable truth which we can understand through scientific methods, but we never quite get there in terms of being able to fully understand what that observable truth is. And so this kind of philosophy is more like a courtroom where we build up evidence around what the observable truth is. And that kind of plays into some of the methods you'll see, this idea of building up evidence as someone might do in a courtroom. Fundamental to realist reviews is trying to understand mechanisms. So that's, I guess, factors which lead from one thing to another. And again, we'll talk a little bit about mechanisms. Like I kind of scraped the surface of realism. The people who get really into the methodology spend conferences talking about what's the difference between a mechanism and a context. And people still can't quite agree on what the definition of a mechanism is. And it also tries to identify these mid-range theories. So mid-range theories are patterns in data. So the idea with mid-range is that it's not very granular and so context specific that it can be applied to anywhere else. It's not just about, for example, older white people in Great Yarmouth, where it's so context specific, it's of little use, or so high level that it's again of little use, where it's more, I guess, conceptually so high level. It's just saying things like unhealthy lifestyles lead to poor health, which it's kind of meaningless. So try to get mid-range and identify patterns. It's not looking for rules which apply all the time, but rather patterns in the data. Again, it iteratively tries to build these theories. So this is the side of in a courtroom building up evidence over the course of time. And that's either through primary studies, whether it's doing a realist review or collecting data to try and build these theories and test them. You might have come across this idea of how, why, for whom, to what extent, and what circumstances. So this speaks to that explanatory nature of realist methods. Realist research was really set up to try and understand complex interventions which are context dependent. So it doesn't work very well for drug interventions where we're interested whether this hypertension drug leads to a reduction in systolic and diastolic blood pressure. That is useful for complex public health interventions. It's based on a lot of work by someone called Ray Possons. He's a professor of sociology in Leeds, and he's written a lot about complexity. And this is really one of the founding principles of realism. In this book, The Science of Evaluation, it kind of sets out how complexity arises and why it exists. And he talks, this is his mnemonic in the book. So he talks about things like, people make choices in interventions. We can design intervention, design services, but people are always going to make choices. The choices aren't infinite. There's usually just a series of choices, but they make choices. So, if we have a smoking cessation service, people choose to either take part or start off and then not attend or not engage at all. So people make choices, and to them it's rational. Well, to outsiders, they may look irrational, but people make choices. We know that implementation is complex. It's not just the case that we implement something and it takes off, but there tends to be a process of persuading local stakeholders, trying to redesign services, doing patient engagement and feedback. There's quite often a learning curve with implementation. So implementation is complex. That there's contextual factors, whether that's a pandemic or whether it's fiscal constraint. So there's lots of different contextual factors in there. They could be anything. There's always a time component that some things take much longer to implement and take time to accumulate, and motivation. Other programs seem to take off very quickly. Outcomes, there's usually not just one outcome. Programs have lots of different outcomes. Some of them are the outcomes we want, some of them are outcomes we don't want or we don't expect. And the outcomes tend to be both short-term and long-term. There can also be competition with interventions. So, if we have a smoking cessation intervention, we know that actually there's competition with e-cigarettes, for example. So there's that competition or rivalry depends on different contextual factors as well. And then things change. So there's this idea of emergence that, as interventions are implemented, things move and change. So in terms of a bit of background to where realist methods came from, so there's this whole literature around realist philosophy. These two chaps here, Rob Possons and Nick Tilley, are the two people who, I guess, developed research approaches. They published 3 main books, which are shown there. And essentially, it all hinges on this logic of analysis, context, mechanism, outcome, which is a CMO or CMOC, as you may have seen it. And I'll talk a little bit about it. Like the CMO part is a specific type of causation called generative causation, where in one particular context it triggers a mechanism to which generates an outcome. So it's this particular logic of causation, and it's the idea is to try and produce these mid-range theories which are then transferable. So it's not just specific to one topic or area or context, but actually it's transferable evidence. Okay, so when we're thinking about complexity, we know that people that take part in complex public health or health services interventions, that they make different choices. And within complex interventions, those choices aren't infinite. They tend to follow patterns. And those patterns that you choose depend on the contexts. So, for example, if we have a smoking cessation service and we decide to place it in the middle of the countryside in that context, the choices that people make depend on the context, and the context may be actually that there's limited travel, it's inconvenient, and so we can start unpicking. Well, why do people make certain choices? What are the contexts in which they make those choices, and what mechanisms do they trigger? So one context may be actually if you look at smoking cessation services in the countryside, it triggers a mechanism of inconvenience, which leads to people not turning up. So those are the types of context mechanisms which we try and unpick in complexity. And the reason we're trying to unpick them is that we know that there's lots of things happening with interventions. So in this diagram, if you imagine the square being a public health or health services intervention, we know that there's lots of things, lots of interactions happening all the time. And that's either between different stakeholders, within the service, and actually lead to lots of different outcomes. And part of realist methods is trying to explore this black box of complex interventions to try and understand, what mechanisms are being triggered and why are they being triggered. So if we think about this idea of CMOs and trying to understand this idea of generative causal models, if we think about an individual going from smoking to not smoking, from B to C, we know that there's something which could trigger that, some mechanism that leads that leads them from smoking to stop smoking. That often happens in a context, and that context could be for example, the smoking cessation service. In the context of a smoking cessation service, it triggers a mechanism of motivation or enthusiasm to give up, or financial considerations or whatever. So within that context, it triggers a mechanism which leads from B to C. And this is the kind of premise of realist logic of analysis. And so that's how we come up with this CMO configuration. So within the CMO configuration, what we're saying is that there's a set of contexts, and within those contexts, it triggers a mechanism, and the mechanism leads to an outcome. The context is quite often described as an intervention. So when we're doing realist evaluations, the context is the service we're trying to evaluate. So what is it about that service? When we introduce that new context or change the context, actually, what mechanisms are triggered and what outcomes are produced. So that's a kind of CMO logic. We can talk about more about that hopefully in a few minutes if you're interested. In terms of realist review, there's a fairly standard structure for undertaking realist reviews. They follow some of the basic principles of any literature review, whether it's systematic review or narrative review or meta-analysis, where it's a case of searching for body of literature. And the key differences are that at the start of the process, we develop some initial program theory. So that's us, I guess, sitting down as a research team or as a group of stakeholders or an expert panel to think through actually what do we think is going on in this service or in this intervention. And so that guides the search. And then within the search, once we've gathered all the papers that we want to look at, then it's a case of analysing it through a CMO logical analysis. And I can share some links to some realist reviews we've published if it's of interest. My experience as realist reviews are a lot more flexible. So it gives space to do some additional searching, gives space to explore more theory and different avenues, gives more space to include pre-existing substantial theory from other areas as well. So compared to a traditional systematic review, they're a lot more flexible in that way. In terms of realist evaluation follows I guess, a similar pattern. It starts off with realist evaluation questions, and again tries to develop this initial program theory, which I guess would be akin to something like a logic model. It's describing, I guess, what the research evaluation and the stakeholders think is going on, and that guides evaluation. Sometimes or quite often the realist program theory or the initial program theory is completely different to the results, but that's part of the process. And then throughout the realist evaluation, it's a case of designing the methods, the data collection methods, collecting data, analyzing through it, CMOC, synthesizing it, refining it, etc., etc. As I say, it includes both quantitative and qualitative data. Although it's pretty difficult to do just with one of those. Realist evaluations work best when there's some quantitative outcome data, which then is informed by qualitative data to try and unpick some of those mechanisms and context. So that's realist evaluation. Quick run through. Okay, so just to show you our example, so this is Equalize. This is a realist review we've just published in the Lancet Public Health. You can have a look at it. And I'll just run through. I'm not going to go through the detail of the results, but I want to just give you a flavour of how we did it and some of the thought processes behind it. So the aim of the project was to try and identify interventions or aspects of routine care and general practice which increase or decrease inequalities. We knew we weren't going to come up with a list of interventions, but the idea was to try and identify principles. Again, that kind of speaks to the realist methods of, we knew that that we wouldn't be able to come up with a list of primary care interventions that would address inequalities, or if we did, then it doesn't work to say actually this intervention is going to address inequalities, because we know that in different contexts in different parts of the country things work to a greater or lesser extent. So we wanted to try and identify principles, and so we started thinking about pre-existing theory which we wanted to include in the realist methods. So we knew that power is really important in inequalities. And so power was one of our substantive theories which informed the design. We knew that intersectionality as well was important in terms of inequalities. Again, we kind of built that into the design of the review, and especially thinking about how disadvantage accumulates. This is our we knew that there was also lots of different elements of primary care. Actually, we didn't want to just look at the GP patient consultation, but we knew that there was structural factors such as workforce and funding and cultural things, and so this was a domains of power framework which had already been described in the literature. So again, we wanted to kind of organize our thoughts and our data in a kind of logical way. Yeah, so that's intersectionality as well. And so what we did is, first of all, we sat down with our research group. We came up with some initial program theory. We then searched the evidence, extracted data, and then started pulling together some of these CMOs, and then came up with that overall program theory. And I'll kind of quickly canter through each of those steps. So this is what our initial program theory looked like. You'll see our final outcome was completely different, but essentially we sat down in an expert panel and with the research team and kind of came through and started talking to them about, how do inequalities arise in primary care? What could we do to address inequalities? And we came up with lots of different things which came out. Like this is particularly useful because, when we then come back to start thinking about the results, we can cross-check with some of our initial thinking. It's helpful as we search the literature because, again, something like inequalities in primary care could be massive. This gives us a bit of a framework to start thinking about the literature as well. Anyway, that was what our initial program theory looked like. The details less important rather than just to see what's like. We then went through the process as anyone would do who's doing a literature review of doing a search across Medline, Embase, Web of Science, etc. So we did a big search. We found lots of systematic reviews. We then opened up the systematic reviews, screened all the primary studies within the systematic reviews, and eventually came up with 325 papers. So we went through a fairly standard Prisma process of identifying studies. We ended up with loads of studies, and actually within the review, we knew we would be able to analyze and code 325 studies. So we took an approach of thematic saturation. So we started analyzing the data. When we got to about 160 studies, and we got to a point where we thought, actually, we're not finding new data, new themes in this data, in the studies. So we felt we'd reached thematic saturation. Those of you with qualitative backgrounds might be familiar with that kind of concept. Again, that was the flexibility within Realist reviews. It wasn't a systematic review. We weren't trying to capture every single study under the sun and record every single study. The idea was to look at these patterns in the data. So this is an example of the CMOs. We had maybe about 20 or so CMOs. Sorry, it's a bit grainy, but just to give you an example of what some of our CMOs looked like. So the first one talks about the context where there's a cultural understanding of professionals, with cultural tailoring of services, a deep structural adaptation, positive framing that leads to cultural alignment, empowerment, engagement, self-care, which leads to improved quality of care for minority ethnic groups and disadvantaged patients. So this idea that actually when we have a culturally competent context, it leads to cultural alignment, empowerment, engagement, self-care, which leads to improved quality care. So again, that's probably not rocket science, but that's kind of describing how, if we change the context, if we start introducing interventions which promote cultural competence, then we'd expect this mechanism to be triggered to lead to that outcome. We're not saying it happens every single time, but we're saying this is a pattern which we'd like to, which we're likely to see in reality. They can be positive or negative. So the number 2 is a negative one. So this is where we're in the context of interventions and services which promote behaviour change solely on increasing knowledge among disadvantaged groups. It leads to relevance, disengagement with long-term condition management, which leads to a lack of behaviour change and health improvement for disadvantaged groups. Again, this idea that if we're just giving people leaflets and information and telling them to go and do better, it's likely to not have much of an impact. So hopefully you can see how these CMOs work. Yeah, and so all of this data we've got references for and coded text from published literature. So those are the types of CMOs we came up with. And what we then did was combined all those CMOs in what our overall program theory was around. So this is our CMOs combined into an overall program theory. And so that picks up in the middle, you can see the 5 principles: community-centered, inclusive, flexible, intersectional, connected. I won't go through this diagram in detail, but the idea is hopefully you can see those are the 5 principles we've structured around those 4 power domains, which we talked about, and we've set out different elements of primary care where you can apply these 5 principles. So this is what our initial or program theory looked like at the end, which are, and each one of these are then underpinned by a series of CMOs. And as you can see, this looks quite different from our initial program theory, which is fine. And the next thing we did was we then turned this program theory into a toolkit. Again, I can share the link to that. But in this toolkit then that explains how to use this program theory. It gives case studies. So, what do we mean by community-centered care? Here's a CMO, and this is a case study of what it means in practice. So we're trying to give, in this toolkit, we're trying to give people examples of what CMOs mean in reality for an individual practice or PCN or ICB. So that's a example of our Realist review and how CMOs work in program theory. Just to finish on a few resources. So the Ramses project developed publication standards for realist synthesis and realist evaluation. They've also got a website, which is excellent. It was funded by NHR to try and improve the quality of realist methodology. So if you're interested in understanding more around what context is or what a mechanism is, it's got lots of resources on there. There's also a email server if you want to join a mailing list to talk about all things realist. There's a Ramses mailing list for anyone who's interested. So, so in summary, realist methods are really about understanding complexity and complexity in context. It's kind of arisen from this desire to move away from a judgment of does an intervention work, yes or no, to trying to understand, well, who does it work in what ways, why does it work, how do we unpick some of that complexity, how do we unpick some of the context. It moves quite far away from, I guess, traditional methodology, which tries to reduce evaluations to black or white. Well, I guess I'm thinking about randomized controlled trials where there's a single primary outcome and it tries to reduce it, an intervention to whether it works or not for that outcome, and tries to randomize out confounders and contextual factors. Whereas realist methods push against that to try and unpick the context and complexity. And it tries to open up this kind of black box a bit. You know, realist methods, reviews, and evaluations never claim to be definitive. Again, they're about trying to build theory and a kind of evidence informed and iterative way. So I'll stop there. That's all I've got to say. I'm happy to open up to questions, comments, discussion.
Awesome. Thank you, John. That's amazing. Can I take Chair's prerogative and ask the first one? So I don't know whether the tension's the right word here, but it feels that with realism, and I guess with a lot of other philosophies and approaches, there's two sides to it. There's a realism as an approach, as a worldview, if you like, around how things operate, and then there are realist methodologies which speak to that. And how tightly integrated are those two things? Because sometimes one sees people talking about realism or, you know, taking a realist view. Is it okay to take the approach without fully adopting the methodology, or do they really have to go together? Because if you don't do the methodology, you're only paying lip service to the approach.
So good question. I think certainly my experience is within the world of realist methodologists, there's some people who are very ideologically driven and who tie very closely to the philosophical paradigms. And there's people who are far more pragmatic. I've seen it in both ways. Certainly, I work a lot with Jeff Wong, some of you may know. He's much more on the pragmatic side of stuff. Although I think I guess there are certain principles and rules. I guess from time to time I see stuff described as realist methods, and they just don't look like realist methods. They either don't use CMO configurations, or the CMO configurations are not what any mainstream realist methodologists would understand by context or mechanism. So I think there are still fundamental principles which, if you stray too far from, then there's a risk of being shot down by the majority of realist methodologists. So I think it's, from my perspective, I've been fairly pragmatic about realist methods. I haven't got too engrossed in the philosophical debates, but I've always tried to stay in line with the kind of principles around, you know, what's a context, what's a mechanism, that kind of logic of analysis, the key principles around initial program theory, and using mixed method states and coming up with an overall program theory, etc.
Yeah. Okay. Thanks. Any questions, comments for John? Either hand up or you can put in the chat. Oh, okay. Well, I've got loads, so I'm going to ask another one while people. Oh, we've got great. Well done, Martin. Over to you, Martin.
Thanks, Andy, and hi, John. Nice to see you. John, you talked about context being an intervention, and you think you referred to an example of smoking cessation services, and I suppose it could be any lifestyle intervention, public health intervention, that nature. But I was interested to know whether that context could be more of a natural phenomenon, a change of changing context. But have you done an evaluation on? I can't think of an example come to mind, but any sort of shift in the natural context that might lead to, or environmental context that might lead to change.
Yes, yeah, so very much so. So certainly, for example, the Realist, the stuff we did with Andy looked at access to primary care, and we did a Realist review of access to primary care, and we didn't look at a list of interventions, but we just looked at where the processes go on when someone accesses care, where the context mechanism outcome, and that was a lot of I guess natural phenomenon, whether that's financial constraint and the NHS, or whether there's an aging demographic, or whether there's, I don't know, transport problems, for example. So there's kind of an active phenomenon there. Like certainly in a traditional realist evaluation, the context tends to be the intervention, whereas realist reviews tend to be a bit more flexible in terms of trying to, I guess, unpick some of those more natural contexts which may change and occur. That makes sense.
Anybody
It
else?
does, thank you. Yeah.
Yeah, thanks. Anybody else with any questions, comments? I wonder, John. So you've got which is very, very helpful. You've got the public health practitioner side of you as well as the academic side of you. So thinking about public health practitioners, I'm pretty sure some of the people on this call are working in public health and have come along because they're kind of interested as to whether it'll help them. Could you reflect on that? I mean, you did touch on that in your talk, but somebody perhaps who's less interested in the sort of more real, but how does this help me in my day-to-day work, and what sort of pitfalls are there as well? What does one need to be careful of?
Yes, so for me, my experience is that people working in whether it's public health or the NHS respond really well to this kind of idea. It makes a lot of intuitive sense that actually, one size doesn't fit all. Context is important, complexity is important. So it tends to go down pretty well with kind of policymakers, practitioners. I think it's a really nice move in terms of trying to encourage people to think about context and complexity more. In terms of the pitfalls, there tends to be two major pitfalls. One is it's easy to do a Realist review where you just generate tons and tons of theory, but you don't get that kind of concrete outcomes, whether that's health or economic outcomes, which policy practitioners want. So if someone commissions a Realist evaluation, a Realist review, and you just end up with screens of theory, then actually turning that into meaningful change is difficult. And so certainly I guess over the years of doing Realist methods, I've become a lot more keen on trying to get that this hard quantitative outcomes which policymakers, practitioners want, which need to affect change. So that's one. I think the other another big pitfall is actually, sometimes there's so much theory that's difficult to see the wood for the trees, and so it's not particularly useful if you produce 50 CMOs and some kind of complex program theory with arrows pointing everywhere, which is all very academic. So actually, there's a big step from translating shed loads of theory into something which is useful. Yeah.
And have you seen examples of proper realist approaches being used outside academia without academic involvement? Does it happen? And should it be happening?
Well, so like I've been in meetings where I've talked about realist methods, and some people have said, "Oh, that's what I've been using for years. I just didn't know what to call it." Which I'm
They
not.
probably haven't, have they? Really? Yeah.
Yeah. But what they mean by realism isn't actually realism. But
Yeah.
I think lots of people use the principles of realist in practice. Like I haven't really seen, I guess, someone in a local authority or a practitioner saying, we've done a realist evaluation on the side, which isn't academic. It tends to be more of an academic thing. Yeah.
And there is a benefit, isn't there? At least early on, if one wanted to use realism in your practice, to have those academic links, probably, because it's not, there are challenges in just sort of self-tutoring yourself, aren't there?
Yes, and not like my biggest piece of advice would be, if you're thinking of doing a realist review or evaluation, is to get in touch with someone who's done one before, and that there's lots of pitfalls along the way, whether that's developing the initial program theory or searching or whatnot. And so actually, it's I think it's advisable to get someone on board who's done realist methods before.
And are there any sort of go to? I mean, you mentioned those seminal books on realism, but are there any sort of go to resources that are useful to get people going?
So I find the Ramsey's website probably the most, like, those books are heavy, to be honest. Uh, um, but certainly the Ramsey's website has a lot of kind of how-to guides, or definition guides, which are like 2 or 3 pages. Again, that's from a certain branch of realism, which Trish Greenhall and Jeff Wong et al. Are from. But they tend to be on the more pragmatic end of the spectrum. There's other teams which have a bit more of I guess, have more of the philosophical elements in it. But I guess I find the Ramsey stuff really
Okay,
good.
that's useful. So Rowena's put in the chat that at Essex County Council they're using realist approaches. Rowena, I don't like to pick on people, but would you be willing to tell us a little bit about that, perhaps?
Yeah, of course. And thanks for your talk, John. Super interesting. Yes, so we, my colleague Hebra is also on the call. We use realist evaluation to evaluate a program, a quite broad systems level program that is aiming to reduce physical inactivity across Essex. So huge county, huge initiative. So we find realist evaluation really useful because it is able to capture that complexity, as you've been explaining, John. So yeah, if anyone does want to talk about using realist evaluation in non-academic contexts, I'd be very happy to chat further.
And can I just ask, what was it, Rowena, that got, because that's quite interesting that you saw the benefit to take that approach. What was the sort of seed of that?
I can't talk too much to the seed. It was started before I joined the team. Yeah. But I think with standard evaluations, as John said, you're very much saying, has this worked? Yes or no? Tick box and on you go. But with realist evaluation, you're thinking about how something's worked, why it's worked, and who it's worked for. And when you're working at a really place-based level, that sort of detail can really help inform the development of programs going forward. So it's been useful to capture that complexity and then try and feed the results of the evaluation back in to shape that program going forward. That's in a sort of ideal world. It's obviously difficult working in a local authority context to have that impact and feed it back in to make those changes. But in theory, at least, that is what realist evaluation allows us to do.
Brilliant. That's really good to hear. Thank you. Any other examples of people that have used realism? Or anybody that's sort of interested in using it, that thinks that this could be a good approach for some work that they're involved in? No? Okay, I reckon people are ready for lunch. Looks like it to me. So thank you so much, John. That was absolutely amazing. Really, really good work, and very clearly presented as well, which is challenging to do. So it was a fantastic seminar, and I guess you're up for collaboration, aren't you? You know, you said about working with people that have already been there, so people can contact you if they're interested in collaborating. You might say no, of course, but that's your prerogative.
Yeah, for sure. Drop me a message.
Yeah, brilliant. And we've also got okay, so Caroline has said used realist informed approach in studies of place-based work across Cambridgeshire. Happy to chat about that sometime. So yeah, so we have got some examples of realism being used, which is really fantastic. All right, well, thank you very much, everyone. Thanks for attending. We're going to be running some more webinars after Christmas, and I will be sending out an email which details them soon. If you're not on the email list, I have just put in the chat my email address. So drop me an email and I can get you signed up, and then you can find out about our future webinars. And if you have colleagues that weren't able to attend this session today, but you think they would benefit from having a look at it, hopefully it will be on the Fresh website within the next day or two. So I'll get that uploaded. So once again, many thanks to all of you for coming. Thanks for a fantastic webinar, John. Really nice to see you again and hear about that great work that you're continuing to do. So thanks for coming along today.
Pleasure.
Okay, all right. Thanks, everyone.
Thanks.
Goodbye. Goodbye.